Here is a detailed step-by-step laparoscopic procedure for Roux-En-Y gastric bypass Lrygb, the most commonly performed type of gastric bypass surgery. This version specifically outlines the laparoscopic approach used by surgeons. Laparoscopic Roux-En-Y gastric bypass Lrygb, step-by-step procedure. Preoperative preparation. Patient positioning. Supine, reverse Trendelenburg position. General anesthesia. Endotracheal intubation. Prophylaxis, antibiotics, venous thromboembolism prevention, compression stockings, LMWH. 2. Establish pneumoperitoneum. Use the Varus needle or open Hassan technique at the umbilicus. Insufflate the abdomen with CO2 gas to a pressure of 15 mm/Hg. 3. Port placement trocars. 5 to 6 ports typically placed. 1 umbilical port, 10 mm. 2 epigastric port, liver retractor, Nathanson or paddle. 3 left upper quadrant working port. 4 right upper quadrant assistant or suction. 5 left lateral port stapler access. 6 optional additional assistant port. 4 liver retraction. Insert liver retractor to lift the left lobe of the liver, exposing the gastroesophageal junction and lesser curvature of the stomach. 5 creation of gastric pouch. Dissect gastrohepatic ligament along the lesser curvature using electrocautery. Identify and preserve the vagus nerve and left gastric artery. Using endoscopic linear staplers, create a 15 to 30 milliliter pouch. First staple horizontally, then apply 2 to 3 vertical staple loads to separate the proximal stomach. The pouch is fully separated from the gastric remnant. 6. Division of the jejunum. Identify the ligament of Treitz. Measure 30 to 50 centimeters distal to the ligament. Divide the jejunum using a linear stapler. The distal end becomes the Roux limb, carries food. The proximal end becomes the biliopancreatic limb, carries digestive enzymes. #7. Creation of the gastrojejunostomy, GJ. Bring the Roux limb up to the gastric pouch in an anticolic or retrocolic route. Create an enterotomy on the Roux limb and a gastrotomy on the pouch. Perform a side-to-side gastrojejunostomy using linear stapler, most common, close the common opening with sutures, or hand-sewn technique in high-risk cases. Ensure adequate caliber 1.2 to 1.5 centimeters to prevent stricture. Creation of the jejunojejunostomy. Measure 75 to 150 centimeter down from the GJ site along the Roux limb. Create a side-to-side jejunojejunostomy between the biliopancreatic limb, proximal, the Roux limb, distal. Use a linear stapler and close the common enterotomy. 9. Closure of mesenteric defects. Close 2 critical spaces to prevent internal herniation. 1 Peterson's defect, between mesentery of Roux limb and transverse colon. 2 mesenteric defect at the jejunojejunostomy. Use non-absorbable sutures or tacking devices. Leak test. Insert nasogastric tube or orogastric tube into the pouch. Fill the pouch with methylene blue dye or air underwater to detect leaks. No bubbles or dye leakage equals no leak. 11. Optional drain placement. A closed suction drain, e.g. JP drain, may be placed near the anastomosis if the patient is high risk, revision or difficult dissection was performed. 12. Desufflation and port closure. Release CO2 gas. Remove trocars under vision. Close 10 mm port sites with fascial sutures to prevent port site hernias. Skin closed with absorbable sutures or staples. Postoperative care summary, timeline care, NPO, IV fluids, pain control, DVT prophylaxis. Day 1, leak test, clear liquid diet if tolerated, encourage ambulation. Day 2 to 3, full liquids, monitor for signs of complications. Week 1-2, advance to pureed diet, remove sutures or staples if used. Long term, lifelong vitamin supplementation, B12, D, calcium, iron, multivitamins, and follow-up. Benefits of laparoscopic approach: smaller incisions, less postoperative pain, shorter hospital stay, faster recovery, lower infection risk, better cosmetic results. Thank you. Have a nice day.